And welcome. I'm Dr. Jayne Morgan, and we are here in this webinar, which is part two of our series, really looking very closely at menopause and those menopause symptoms geared towards educating the community. In part one, if you missed it, we covered the basics. What is it? What are the symptoms? What are the first steps that you can take? What are the treatment options? And we were right here with Dr. Sandra Reed, who's back with us again for part two. I'm so happy to have her. Thank you and welcome, Dr. Reed.
Hi, Dr. Morgan. How are you today?
I am
Uh,
doing well, and I think I'll be doing better after this webinar, after I've learned so much more from you. I'm looking forward to it.
I'm excited to be here today as well. I've been in practice for more years than I'd like to count, but the last about 15 years, I've centered my practice around menopause and the interest of women's health. And currently, I practice gynecology at Emory University and have a focus on menopausal medicine. So today is right up my interest.
It really is. And we are honored, and it is really a privilege to have you with us today. You are a wealth of information and all that experience. We are going to lean on it and lean into it to get the answers that we need. So, let me ask you, we're moving into part two. So, alongside menopause, what are other changes occurring in the body? So we know menopause is when the menstrual cycle has stopped for 12 consecutive months. So, in addition to just your period stopping, what are some of the other changes that are happening? And maybe we could even talk about what are some of the changes in the heart as well.
Yes, at the same time that we are transitioning into menopause, our body is undergoing a lot of other hormonal changes as well. This is also the time where we naturally start losing some of our growth hormone, which is some of the vitality and helps to keep us young. But we also see gaining weight. You know, everybody talks about getting weight right in that midsection where they can't get rid
Mhm,
of it. That's very
mhm.
typical during menopause. Yeah, yeah, I can raise my hand too. And it seems to be really hard to get that weight off.
Mhm.
Alongside, if you think about what's happening in life when we transition through menopause, a lot of us are going through empty nests. So we get a lot of emotional changes occurring at that time, other body changes, sleep disruptions. And if you think about it, these can also mask depression and other medical issues besides menopause as well.
Mhm.
Natural aging, mental health issues, and menopause all carry some of the same symptoms as we transition. We know that we have sleep interruptions, and as far as our cardiovascular health, some of the things we know, estrogen is a stabilizer and of the blood vessels, and it helps to dilate and keep our blood vessels more pliable.
Mhm.
And as we lose those hormones, we lose that capability in the heart as well. And we do see some disruptions in that. Estrogen helps to decrease our cholesterol and keep that in check. So when we age, we notice that our cholesterol creeps up naturally as well when we lose that estrogen. And it can also, the decrease in estrogen can lead to plaque formation and buildup, stroke, heart attack, coronary heart disease. And in the disruptions of sleep, we know that uh, the hot flashes occur in the second part of sleep, which is also when our REM sleep occurs. So 41% of
That's
our,
very interesting.
excuse me,
That's very
yes,
interesting.
41% of the hot flashes occur in the first part of sleep, and 59% of hot flashes occur in the second part of sleep. And
Mhm.
that's when we have the most REM sleep.
Mhm.
And when we interrupt the REM sleep, it interrupts the thermoregulating part of our brain.
Mhm.
which is where the hot flashes stem from. So yeah,
Mhm.
the loss of estrogen plays a role in a lot of our body functions and a lot of issues that we don't really think about.
And so are hot flashes that you have during the day the same as night sweats? Hot flashes are just night sweats are just hot flashes that you have at night, or is it not? It has something more to do with the thermoregulatory system.
It is about the same. It affects the thermoregulatory system. Women just tend to have more when they transition through menopause at night than
Mhm.
they do during the day. Whether it's they're just paying more attention to it. It also tends to interrupt their sleep. Whereas when you're awake and you have one, you might just fan a little bit and brush it off, but at night, when you're having them and it actually interrupts your sleep and wakes you up, you're definitely more aware of it. But statistically, women have night sweats and hot flashes more at night. And a hot flash is when you just feel this instant heat, like your own personal climate change. And
Right.
then the night sweats, you hear patients talk about, and maybe you yourself having to come out of your pajamas 2 and 3 times a night because you just soak the sheets in your pajamas. All of those symptoms can occur in severe cases, especially.
Mhm. So the takeaway from that I am hearing, because I've heard this so many times from women to say, you know what? I have never had a hot flash in my life. I do have night sweats, but I've never had a hot flash. So here's a news flash. You are having hot flashes. You're just having them at night. So night sweats are hot flashes that occur at night. So that's for all of you out there who say you've never had hot flashes. You only have night sweats. Let
Yeah,
me ask
they're
you this.
very similar.
They're very similar.
Yeah.
So in order to get this information, what about the heart? You know, as a cardiologist, I'm really interested and focused on it. So, what can we say about the changes that are happening in the heart at this time?
Well, as we lose our estrogen, we lose that elasticity, and it can affect the vessels of the heart.
Mhm.
Also, a lot of women, when they go through menopause, have arrhythmias, are very common. And it's that fluctuation of hormones. And I apologize for my dog barking in the background if you all can hear her. But it's a
There.
fluctuation of the estrogen levels that stimulates those
Mhm.
arrhythmias as well. But in particular, at night, women may complain of having a lot more of those fluctuations, fluttering of the heart. That can occur as well.
With those symptoms. And is the risk of heart disease higher in a woman as she goes through perimenopause and menopause? Is that something she should think about or her physician should think about?
It is certainly something she should think about, especially if she has a family history of cardiovascular disease, and especially Um, maybe her mother had a heart attack at an early age. That's something definitely that we want to have a conversation with our patients about. Family history is extremely important as we age, as we transition, and it is something that she needs to discuss with her physician as well.
Okay, shifting topics just a bit, still in menopause. Let's talk about premature ovarian failure. We hear that, but what does that really mean?
Premature ovarian failure is when the ovaries, for whatever reason, stop working before the age of 40.
Well, stop working,
Early,
meaning that they're not producing eggs anymore, or they don't produce estrogen anymore. What does it mean when they stop working?
it actually means both. They stop producing the estrogen, and
Mhm,
patients usually know that by the symptoms of menopause that they have, and they'll come in complaining of those symptoms. But when you lose your estrogen at an early age, you also lose that ability to create the eggs and ovulate. So it
mhm.
can affect fertility. And if you have a family history of early menopause, it's something that you need to discuss with your gynecologist early,
Mhm.
so that you can address those issues and stay on top of that. Some of it is genetic. Other causes can be, you know, certain cancer treatments can cause premature ovarian failure. So there are other causes of it that your physicians need to be aware. If you've had a childhood cancer and was treated, that can affect your fertility in the future and cause some premature ovarian failure as well. So, definitely, if you have any of these histories, you should let your physician know. And early menopause is considered that time frame between 40 and 45 when you naturally transition into menopause, but just as an earlier age. And then after age 45, it's considered a normal time frame for menopausal change.
Let me ask you, since we're talking about ovarian failure, we get this question all the time. What does FSH mean? And should you go to your doctor and have these levels drawn, or are the levels variable, or what does all of this mean?
So FSH is follicle stimulating hormone. It's a hormone that's released by the brain, the pituitary gland specifically, and it causes the ovaries to produce estrogen. It's a precursor that just tells the ovary what to do and when it's time to produce higher estrogen levels or lower estrogen levels. And it's released in order to manage the normal hormonal cycle. And it does vary during the cycle. When you start your cycle, your period, we consider that as the first day of your new cycle. Um, the FSH and estrogen levels will be at their lowest. And as you transition through a normal hormonal cycle, the FSH will increase slightly, and that stimulates the ovary to increase the estrogen. And then the body, it's a miraculous organ. I mean, our whole system. To think about, the body knows what it's supposed to do when it's supposed to do it, and so it because of the hormones, the body's telling the ovary in order to stimulate ovulation, so that an egg is created, and then the creation of that egg causes the release of other hormones that stimulates ovulation. And then the FSH and estrogen are pretty steady through the rest of the cycle. And then they fall again, and that stimulates the menstrual cycle to begin again, and stimulates the body to shed the lining of the womb. So, about checking the FSH. As you go through menopause, the FSH is elevated because the body's trying to tell the ovaries they're not doing their job and they need to be producing more estrogen. So, by releasing the FSH, it's really trying to make that ovary produce the estrogen levels that the body needs to cycle. Um, and you can check the level, but a lot of times, well, actually, most of the time, if you come to a gynecologist and say, I'm having menopausal symptoms, we're really going to treat based on your age and what your symptoms are. And if you're in that natural transition cycle, we would probably just recommend treatment if you're having severe symptoms.
Mhm.
If you're in early menopause, then yes, we're going to check your FSH level along with some other hormone levels that can cause decreased periods and um, mimic menopause. Um, I'm going to say we do have a home test now that is available to check an FSH.
Mhm.
If you want to check that to see if it's elevated, to see if you're going through menopause, you certainly can do that. It's very easy to do, just like a home pregnancy test. The
But it could
issue
mean
is, though,
you're ovulating as well. Could it mean that you're ovulating
yes,
as well?
It could be. Sometimes it can cause you to have more concerns than it's worth to do the test. And it might be best just to go have a conversation with your physician, so that
Well,
you
whatever
can.
the results are, they should talk with their friend, right?
Absolutely, absolutely. But in order to get your questions answered as well,
Mhm.
and there are other things that can cause you to miss a period, like an elevated thyroid. Hormone level can and or your low thyroid can affect your periods. So you need to. Uh, it's for information only. If
Uh-huh.
it makes you feel better, it's not going to hurt you, but it may raise more questions than you have answers for, and it may send you to see your physician, which is actually what I think you should do in the first place.
Right. So beware of checking labs. They may indicate something and may indicate nothing. They may be they may give information, or it may just be all over the place depending on where you are in either your menstrual cycle or in premenopause or menopause. So talk with your doctor always. Let that person interpret those results. Um, when you talk about who needs to have these labs and talk about the symptoms, is there anybody who really needs to have these labs? Or, I mean, how do you determine when you're drawing these labs in your office who actually needs them?
Certainly, someone who comes in with symptoms who are early, less than 40, or
Mhm,
sometimes even in that 40 to 45 year old range, just to get an idea of where you are in your cycle. And I usually recommend my patients get these labs drawn during their period,
mhm,
so that we know that these hormone levels are at their lowest.
mhm,
And your FSH should be elevated because it's getting ready to push that ovary to start making more hormone.
mhm,
And if it's elevated during your period, we know that you might be starting through that menopausal transition.
mhm.
Um, if you're garden variety menopause, I usually do not immediately jump to getting labs. I'll take a history, we'll have a conversation, we'll talk about hormonal replacement, the risks and the benefits. And if we both agree, and this is a patient choice discussion, as most discussions should be with their physicians. If we decide to try the hormones, I usually give about a 2 to 3 month trial, and then bring the patient back in and have a conversation about their symptoms and whether this has relieved them. If they are on an adequate dose of hormonal replacement therapy and they are not getting relief, I would then do the labs as well.
Okay, let's then talk about hormone replacement therapy. What does that even mean? Is it estrogen? Is it progesterone? Is it both? Is it growth hormone? Like what is it testosterone? What's being replaced?
Your typical hormonal replacement, if you still have a uterus intact, is going to be estrogen and progesterone. Estrogen, unopposed when you still have a uterus, can affect the lining of the womb and make it overgrow, and over time can develop into abnormal cells. So we always treat the patients who are on hormonal replacement who still have a uterus with both estrogen and progesterone.
Okay.
Testosterone we don't use as much, but occasionally there is an indication to use it in patients who have low sexual drive, and problems with libido. I would always treat with estrogen first because you need that, and that may be all they need to
Mhm.
treat that decreased sex drive. And then I would check hormone levels with the testosterone before starting it. There is
Uh,
not a testosterone product currently on the market that is directed for treatment for women.
mhm.
You can use the products that are designed for male issues, but you only need about 1/10 and
Mhm.
the way they are distributed makes it really difficult to treat with a FDA approved testosterone product. So we usually, if we are going to treat with estrogen, have to write a prescription for a compounded testosterone product that a compounding pharmacy would have to make. And we usually use a cream for that because we know that testosterone is not absorbed orally very well. It absorbs better with a topical approach. And then
Okay.
that brings up the question about what are compounded hormones and whether we should use compounded hormones or pellets or other alternative types of estrogen. And there's not enough data to look at real good studies looking at compounded versus FDA approved products for hormonal replacement. So, the statement for our national organization as far as compounded medications is that we should use those products that have been studied first, the
Mhm.
ones that are FDA approved. You know what you're getting within a appropriate standard deviation. You know what the amount of hormone you're getting. And in compounded products, hormones, a very tiny change can make a huge difference in what you are absorbing.
Mhm.
And some of these compounded formulations can be all over the place. And I get a lot of questions about pellets.
Mhm.
The problem with pellets is that they are compounded as well. And
Mm.
besides the fact that most insurance companies are not going to pay for a compounded product, once the pellets are placed in the tissues, they usually are inserted just under the skin subcutaneously in the fat layer of the hip or lower abdomen. And once they're there, they are there for 6 to 8 months,
Mm.
depending on your metabolism rate. So if you have a side effect from it, you can't take it back out. It has to be absorbed. And we always monitor testosterone use with labs just to make sure we're not getting too much because we can get too much. And then for women, that could cause some side effects that are not really desirable, such as
Mhm.
increased facial hair growth, deepening voice, or increase in the size of the clitoris. So it's something that you need a physician who is very versed at treating with testosterone and reliable to follow up if you are being treated with it.
Such good information, Dr. Reed. And what I'm hearing with testosterone is, and you can correct me, it's better to use the FDA approved version, even though it's approved for men, and to try to measure 1/10 of that dose than to go to a compounding pharmacy and have something specially formulated just for you. It's better to try to get 1/10 of the dose that's available for men. Is that true or?
Well, not necessarily because it's really difficult to get just 1/10 of a
Right.
packet of
It's,
gel.
it's an
Uh,
estimate.
Yeah, it is an estimate. So I would say that the testosterone is one of the things that compounding is easier to use in female patients. You just need to have a physician that's going to follow up with you on your testosterone levels specifically to make sure you're not getting too much, even with a compounded product.
So, Dr. Reed, it's been such a pleasure to have you with us today for the second time. But before I let you go, I have to ask one more question, and that is family history. What guidance do you provide your patients with regard to how family history may impact their premenopause or menopausal journey?
I always ask how old their mother was when she went into menopause.
And
And
do
you would be
patients
surprised.
generally know? Do they is that something even do we
That's
even
what I
talk
was
to our
about to
mothers
say.
about
You'd be
it? Right.
Yeah, you would be surprised how many women don't know when their mother went through menopause. It's just something that they never discussed, or they had a hysterectomy, so they don't know when they went through menopause. Because when their mothers were having their hysterectomies, it was very common to take the ovaries out
Right.
at the time of surgery, and they would automatically go into menopause at that
Right.
point. So I then asked, "Well, do you have a sister who has been through menopause?" "No, I only have a brother."
Right.
So
An
that's
older
no
sister,
help.
right.
But family history does play a role, and if you do know, when your mother went through menopause, you can pretty well mirror that that's going to happen to you. And that would be around the general age of menopause
Mhm.
for you, and that makes it even more important if you know that your family history is that the women go through menopause early, to let your physician know that that does run in your family and it is a family history. So, yes, family history is important, and it gives you an idea of when this is going to happen, and you can be prepared when you start having those hot flashes, that this is what's happening to you. And to those women out there who have never had a hot flash, they are among the few, and
Right.
they should consider themselves lucky.
And you know something else, you've prompted women to say to themselves, maybe I need to have this conversation with my mother. We've never talked about this. We talk about our
Right.
first period, we talk about having sex, but we don't talk about what happens during menopause and what age that starts. So thank you for prompting that conversation. I absolutely want to thank the audience today for tuning in for part two. We're moving on to part three. So if you didn't catch part one, go back, catch part one. It'll catch you up to where we are today. And we're moving on with part three with Dr. Reed. But this was part two. We're so happy to have you here. And thank you so much, Dr. Reed, for joining us.
Well,
So,
thank you. It's been a pleasure.
this is our latest episode from the Medical Association of Atlanta's webinars. See you next time.